Thyroid-related menstrual disorders are problems with a woman's period that happen because the thyroid gland is not working properly. The thyroid makes hormones that help control the body's metabolism and also affect the reproductive system. When thyroid hormone levels are too low or too high, periods can become irregular, heavy, or stop altogether, which can affect fertility and overall health. Hypothyroidism, under active thyroid, often due to Hashimoto's thyroiditis or pituitary problems. Hyperthyroidism, overactive thyroid, most commonly Graves' disease or a toxic multinodular goiter. Iatrogenic, taking too much or too little thyroid medication, or using antithyroid drugs. Post-surgical, radioactive iodine, removal or destruction of thyroid tissue can change hormone levels. Autoimmune overlap. Many women with polycystic ovary syndrome also have thyroid antibodies, linking the two conditions. Thyroid hormones talk to the brain's hypothalamic pituitary gonadal axis, HPG. Too little thyroid hormone makes the brain send mixed signals, lowering the pulse of gonadotropin-releasing hormone, GnRH, and changing the release of LH and FSH, which control the ovaries. It also raises sex hormone-binding globulin, SHBG, so less free estrogen and progesterone are available. Too much thyroid hormone does the opposite. It speeds up GnRH pulses and lowers SHBG, leading to excess estrogen activity. Both extremes can disturb how the ovaries make steroids and cause irregular bleeding. About 20 to 30% of women with untreated hypothyroidism report heavy or irregular periods, while 10 to 15% of women with hyperthyroidism notice lighter or missed periods. The problem is most common in women aged 20 to 45, especially in regions with iodine deficiency. Autoimmune thyroid disease is more frequent in people of Caucasian and Asian descent, and many have another endocrine disorder such as diabetes or PCOS. Oligomenorrhea or amenorrhea, periods become far apart or stop. Menorrhagia or metrorrhagia, very heavy or unpredictable bleeding. Dysmenorrhea, painful cramps. These often appear together with classic thyroid signs, fatigue, weight gain or loss, feeling too cold or hot, hair thinning, and mood swings. Some women also face difficulty getting pregnant or experience early miscarriage. Ask for a detailed period calendar. When periods start, length, flow. Feel the neck for thyroid size and look for skin, hair, or weight changes. Blood tests, TSH, free T4 over T3, thyroid antibodies and reproductive hormones, estradiol, progesterone, LH, FSH, prolactin. Ultrasound, thyroid scan to see nodules, pelvic scan if ovarian cysts are suspected. Rule out other causes such as uterine fibroids, clotting disorders, or pregnancy. When TSH is high with low T4 and the period is heavy, the diagnosis is hypothyroid-related menstrual disorder. When TSH is low with high T3 over T4 and periods are light or absent, it is hyperthyroid-related. Hypothyroidism-related, primary thyroid gland versus secondary pituitary patterns. Hyperthyroidism-related, mainly Graves' disease or toxic nodules. Mixed or fluctuating, patients who swing between over and underactive thyroid. Subclinical dysfunction, abnormal TSH but normal T4, T3, yet periods are still affected. Autoimmune overlap, when thyroid antibodies coexist with PCOS or other autoimmune diseases. Explanation, treat the root thyroid problem first. Hypothyroidism, start or adjust levothyroxine, check TSH every 6 to 8 weeks until stable. Hyperthyroidism, use methimazole or PTU. Consider radioiodine or surgery if needed. Once thyroid levels are normal, menstrual symptoms often improve. If periods are still irregular, doctors may add hormonal contraceptives, cyclic progestin, or NSAIDs for pain. For women trying to conceive, Fertility specialists may use letrozole or gonadotropins after thyroid control. Follow-up visits include checking thyroid labs, reviewing bleeding patterns, and discussing lifestyle, balanced diet, stress relief, adequate iodine. The best way to avoid problems is early detection. Screen thyroid function in any reproductive age woman with unexplained menstrual changes. Check TSH each trimester of pregnancy and again after delivery. Keep a steady intake of iodine-rich foods, seaweed, dairy, fish, and avoid extreme dieting. Manage stress with yoga or mindfulness, because stress can worsen both thyroid and menstrual cycles. Take thyroid medication exactly as prescribed and report any new symptoms promptly. If thyroid levels are corrected quickly, most women regain regular cycles within 3 to 6 months and have a normal chance of pregnancy. Persistent untreated thyroid disease can lead to chronic amenorrhea, reduced bone density, and lower quality of life. Proper management also lowers the risk of cardiovascular disease and improves mood and energy. Certain gene variants and epigenetic changes link thyroid autoimmunity to menstrual irregularities. Small RNA molecules, microRNAs, in blood may predict who will get better periods after thyroid treatment. Selective thyroid hormone receptor modulators are being tested to fine-tune hormone effects without causing heart problems. Large cohort studies, for example the UK Biobank, reveal that even subclinical thyroid dysfunction raises the odds of heavy bleeding. Pharmacogenomic tools are helping doctors choose the right levothyroxine dose for each patient, reducing trial and error.